regarding the prenatal diagnosis of autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease is the most common genetic nephropathy. It affects in 1 in 400 to around 1 in 1000 live births. Usually it presents in the third or fourth decade of life, but it can complicate one's childhood with complications like abdominal pain, hypertension or proteinuria. Most of these cases will ultimately progress to end-stage renal disease and may require renal transplantation in adult life. It usually presents with enlarged echogenic kidney, and by the fourth decade of life there is gross decrease in the kidney function. This has autosomal dominant mode of recurrence, so in every subsequent pregnancy there is around 50% chance of recurrence. It is caused by mutation of the PKD1 gene located in the chromosome 16 in 85% cases, PKD2 gene in chromosome 4 in 15% cases. Another newly discovered gene is the GANAP gene in chromosome 11, which occurs in less than 1% of cases. Mostly the one caused by PKD1 gene, that is the majority of the cases, have a very severe prognosis and will ultimately end in end-stage renal disease, but the other two have a better prognosis. Coming to our case history, a 34 years old primigravida had attended Institute of Fetal Medicine Kolkata for prenatal genetic diagnosis of probable ADPKD in the fetus at 21 weeks of gestation. She was married for 2 years, non-consanguineous marriage. Her husband had developed hypertension and abdominal pain at the age of 30 years, and he was diagnosed with ADPKD based on his clinical phenotype. On pedigree analysis, it was found that his mother, maternal aunts and maternal cousins were also affected with ADPKD in their fourth decade of life. The mother's baseline investigations were normal, all the lab parameters came as normal. So we proceeded with the mid-trimester ultrasound for the fetus, where it was found that the fetus had bilateral echogenic kidney with accentuated corticomedullary differentiation, which is very typical of autosomal dominant polycystic kidney. And there was normal Leica volume and a visible bladder. Ultrasound kidney urinary bladder of the father was also done, and he was also found to have bilateral enlarged kidney with lobulated outline, multiple non-communicating cysts with dilated parenchyma, which matched with his already diagnosis of autosomal dominant polycystic kidney. So we proceeded with amniocentesis. And dual whole exome sequencing of the fetus and the father. On whole exome sequencing of the father, we found a heterogeneous nonsense mutation in the PKD1 gene, which was deemed pathogenic. The same mutation was also detected in the fetus. On top of that, another heterogeneous missense mutation was located in the PKD1 gene of the fetus, but this was categorized as variant of unknown significance and probably had no relation with the phenotype of the fetus. Now the couple was counseled that the fetus was likely to have the same phenotypic expression as his father, and that no prevention was available for autosomal dominant polycystic kidney. Early diagnosis and treatment with novel therapy, which is available nowadays, can delay the onset of end-stage renal disease and complications of hypertension, and also that there is 50% chances of recurrence in every subsequent pregnancies. After that, the couple took an informed decision and opted for medical termination of pregnancy. Now, other differential diagnosis possible in this case was autosomal recessive polycystic kidney disease, but that would have led to severe oligohydramnios and a non-visible bladder, and this kind of corticomedullary differentiation is not seen in case of ARPKD. Other syndromic associations might be Meckel-Gruber syndrome, Beckman-Widman syndrome, Bardet-Biedl and Perlman syndrome. So we can conclude that prenatal diagnosis of ADPKD by USG is solely by USG is extremely rare. Usually the patient comes with a request for detecting it in the fetus, and that can be confirmed by Sanger sequencing or whole exome sequencing of the fetus. And once a disease is confirmed, if the patient plans to continue with the pregnancy, 4-weekly ultrasound to assess the renal anatomy and amniotic fluid volume needs to be carried out. The mother should also have ultrasound KUB to rule out undiagnosed maternal ADPKD, because that will complicate her pregnancy with hypertension. Prenatal diagnosis of ADPKD can be considered when there is a known family history of the disease. It can have a significant psychological implication on the parent due to the uncertainty of the disease. Genetic counseling is mandatory to help them take an informed decision, and if they plan to continue the pregnancy, a multidisciplinary approach is crucial for providing implications of the disease and future management. And since this has got a problem with future planning of pregnancies, they will be provided with alternatives like pre-implantation genetic diagnosis with in vitro fertilization or gamete donation. So the take to walk message is basically that ADPKD, though onset is from the 3rd or 4th decade of life, there may be evidence in utero which we need to pick up, and that can be diagnosed by, like I said, Sanger sequencing or WES of the fetus, and genetic counseling and multidisciplinary approach is needed once that is confirmed. Thank you.